We're live, Professor.
Okay, perfect. I'd like to welcome everyone to Wednesday, May 2026 Grand Rounds. We have some great cases tonight, and I do have a short little lecture to give at the beginning. But first, let me introduce, as always, we have Dr. Hussein Tarek, who is the Chief Clinical Director of ITX Pros, and he does all of our treatment planning. And he told me he has some really, really good cases tonight, which are very interesting. So looking forward to that. Also, we have our longtime faculty member, the Institute, Dr. Rick Robinette, who will be on live, and he will be able to answer any questions. Just go onto the chat room, put your question in, and he will get right back to you. So please keep him busy tonight. And I'm sure there's going to be some questions from the lecture and also from the cases. So, as you know, I always start out with a very short lecture on an interesting topic or a hot topic in implantology. What I'd like to talk about tonight is about medications, especially medications for osteopenia or osteoporosis. As you know, a majority of the medications in the past have been bisphosphonates, which are highlighted there in blue. And one of the problems with bisphosphonates has been the osteonecrosis. More recently, a very, very popular medication, it's not a bisphosphonate, is called Prolia or denosumab. And this also has been associated with osteonecrosis. So if we look at the two drugs, denosumab and the bisphosphonates, denosumab is a monoclonal antibody. They do have an incidence of causing osteonecrosis and complications with dental implants. So if we look more into the monoclonal antibodies, it's popular Prolia. Denosumab is actually comes in two forms. Prolia is the osteoporotic side, and Xgeva is for metastatic cancer. Usually, Prolia is given every 6 months subcutaneous for osteoporosis, where Xgeva is given monthly, a very high, a double dose, and that is usually for metastatic cancer. As we all know, Prolia is a relative contraindication. We do recommend an MD consult, where Xgeva, these patients are usually um, more sick and not really implant candidates. So usually we have that as an absolute contraindication. Now, if we look at the studies on denosumab and implants, specifically Prolia, it's less than 1% getting a osteonecrosis. One of the advantages of Prolia is it has a very short half-life. If you remember bisphosphonates, up to over 10 years, the half-life, and that is problematic. Where Prolia doesn't, it's a very short half-life. So if you look at studies, bisphosphonates have a much higher osteonecrosis incidence than denosumab. However, here's the problem. A lot of patients are being transitioned from bisphosphonates to Prolia, whether they have intolerance to the bisphosphonates or they've been just on them too long. So we're seeing more and more patients on Prolia. So if you take a patient that was on previous bisphosphonates, now they're on Prolia, they actually have a higher incidence than bisphosphonates alone. So you have to be careful with those type of patients. They're going to be in a higher risk category. Now, what is the problem? In the past, physicians would give the patients a drug holiday from Prolia, and it won't be a problem. Now, almost the physicians really frown upon it. They try never to do a drug holiday. Why is that? Because what they're finding is patients that go off of Prolia get a rebound bone loss, or almost like brittle bone disease, where the long bones, they get spontaneous fractures, vertebral fractures, high incidence of this. So these patients are almost never taken off of this drug anymore because of these fractures. So when we look at how do we treat a patient who is on Prolia, Well, it's certainly not an absolute contraindication. As I showed you, the studies are very, very low, the prevalence. If you don't modify it, there is a risk. So now you have a medical legal issue that you could possibly run into. A drug holiday, now the physicians don't want to hold off and give the patient a drug holiday. So a better one is called a delayed dosing window. And let me tell you what that is. Delayed dosing window is done with the physician. Usually they will have you schedule the surgery at the end of their first 6 months after their last Prolia injection. So usually from the 15th day to the end of that fifth month into the 6th month, they'll basically recommend you do the surgery. Then the physician will do a 1 month drug holiday, which has been shown not to have any problems at all. Again, using pre and post op antibiotics and minimize the invasiveness of the surgery, decreases any osteonecrosis. So if we look at it, normally Prolia is given every 6 months. So 6 months, 12 months. In this protocol called the delayed dosing, you give it at the very end of that first 6 months. In those last 15 days, the physician holds off for 1 month and then goes back on the 6 month regimen. This has been shown in Europe to be foolproof. It is documented, it is studied, and has been shown to be very, very effective. So now, you know this drug from the name Prolia. So, as physicians always throw us curveballs, now there are more than one Prolia. What do I mean by that? There is a new category of drugs called biosimilars. Now, what are biosimilars? These are drugs that are similar to the drug in question, Prolia being in this case. However, they're not exact copies. We know an exact copy is a generic drug. This new classification of drugs is called biosimilars, where they're similar, but they're not identical. Now, the interesting part about this, Prolia, the patent expired last year. In the last year, there has been about 8 to 10 new drugs. They're called biosimilars. Now, why am I telling you this? Because patients are going to come in and put this on their medical intake form. They're not going to be putting Prolia, so you might not recognize it. And there's so many of these, so you're going to have to Google this, ChatGPT it, whatever, and see if it is denosumab, if it is biosimilar to Prolia, then it's going to have the same potential issues. I do recommend informed consent with any monoclonal antibody. I do have one on our website. So just go on our website. It's a biologic and a monoclonal antibody. Make sure the patient signs this. You should always have, with any of these medications, a good medical clearance, and the patient should be fully informed. If you want more information, or sometimes the physicians will want to know about that delayed dosing protocol, there's a newsletter on our website. I wrote an article on it. Also, in any of the textbooks, I have it also. But a lot of times you can just print this out and give it to the physician so they understand exactly where we're going with that very short drug holiday and a specific date for our surgeries to prevent osteonecrosis. With that being said, I know we have over 10 cases tonight, so I'm going to go right to Dr. Hussein and let him do his work. So let's go. Dr. Robinette will be on. He will answer any questions you might have about those drugs. And with that being said, let's go. Who's the first case we have?
Thank you, Professor. First case is for Dr. Britterman. Doctor, would you mind unmuting yourself and presenting your case, please, to Dr. Resnik?
Hi, Larry. How are you? Larry, are you there?
I think he's here, sir. I'm just asking Dr. Britterman to unmute himself. Okay, so we could
Can you
go
hear
to the
me
next
now?
case, Professor. Oh,
Can you
Okay,
hear me
perfect.
now?
Larry,
We got you, sir.
you
Yeah,
here?
I'm here. I'm
Okay.
here.
Hi, Larry. How are you?
All right.
Tell us about your patient here. We see a mandible with some natural teeth here.
Yeah, so this is a 47-year-old male. He's in pretty good health. Um, he has a deep uh, class 2 occlusion. He's been kind of sporadic with his dental care. He recently had 3 implants placed on the top, but he's still missing number 3. All those teeth on the mandible, they're all pretty much broken down, and the fronts are kind of uh, pretty worn
So
from
he's had
the
a lot of attrition on him.
yes, from the deep bite.
Okay.
And he is open to any restoration, but in the posterior he doesn't have much bone. He does have somewhat of a the mandible is a little bit C-shaped around those teeth. Um,
Okay.
um, I'm
Hussein, why
think
don't you give us a 3D image of this one?
Yes, sir.
Okay. So Larry, okay. Let's see what we have here. So, okay, just do a 360 on that. So Larry, these teeth are not in the best of shape. Uh, and if we look at a 5-year success prognosis for these, it's probably pretty questionable. The one thing that I see right off the bat, Larry, is this patient's had dental alveolar extrusion. So Hussein, go ahead, extract the teeth. Let me explain what that is to everyone. So do you see how that anterior segment is higher? Show them with a line there. So you said the patient's a deep bite. Is that correct, Larry?
well, he is now. It seems a little collapsed, and
Yeah.
uh,
So these patients, they develop a class 2 occlusion deep bite because the you get wear of the anterior teeth and that whole alveolus super erupts. So where Dr. Hussein put that line there, that is probably more likely where the alveolus should be. So all those teeth have moved superiorly and lingually. That's why you have more of a class 2 deep on this patient. Why is that significant? Because those are hard to restore. Now, what I would tell you on this case, Larry, let's put the teeth back in.
Yes, sir.
I would let the patient know that I mean, you could keep the teeth. I wouldn't suggest trying to put implants in the posterior and keeping the teeth, but you could maybe do something with conventional prosthetics, crown and bridge or partial or whatever. Not that I would recommend it, but at least give him that option. So that's one extreme. The on the opposite side is going to be extract all the teeth. And that's probably going to be the best in this case. So go ahead, extract those, Hussein.
Here we go, Professor.
Okay, and then you're going to need a pretty significant osteoplasty to reduce that so you have restorative space. And then go ahead and place implants for either a partial or a overdenture or for fixed prosthesis. So if the patient, usually when they have fixed teeth, they're going to want to go to a fixed implant prosthesis. So Hussein, did you work this up for a like an
Yes,
FP3?
yes, sir. We
Okay.
did. So what I did is that I go ahead, sir. I'm sorry.
Oh, go ahead. Tell
I
the
was
group what
mentioning,
you did here.
Professor, that I did add 5 implants at the A, B, C, D, E position, tilting the two most distal implants along the mental framing for better AB spread. Um, Dr. Britterman also did plan this case for 6 implants, but I thought I'd go with 5 instead of 6. Let me start by presenting the E position, sir. So that's a 3-3 by 12 millimeter implant at that side, clear away from the mental framing. And Professor, as you've mentioned, sir, we're planning on reducing the ridge by approximately 9 millimeters of vertical height over here at that side at the E position. Then that's the D C position, sir, and the C position we're reducing 11 millimeters of the ridge. And Professor, I did notice a very interesting anatomy over here where the median lingual canal has got a superior insertion and inferior insertion over here as illustrated in my cross-sectional image. That's the B
So those are
position,
median
sir.
vascular canals, the
Yes, sir.
um, sublingual arteries. Okay, perfect.
And lastly, the A position, sir, where we're still using a 3 by 12 over here, clear away from the foramen, and we're planning on reducing exactly 9 millimeters of the
Okay.
ridge as well over here, sir.
Okay. Now you're using Strawman. What is their next size up from a
They do
3.3,
4-1, sir.
four
They have a
one?
3.8.
Okay.
They do have a
They
3.8.
they have a 3.8. Okay.
Yeah.
So show everyone the AP spread on this.
Sir.
Okay. So I like where he has the implants. He by angling them, we're back in almost the molar region, which is great. The only thing that I am a little hesitant about, let's go back onto the pan view and blow that up. Okay. So we're against natural teeth. We probably have a little bit of parafunction there, irregular occlusal plane. So I would, if possible, it doesn't have to be done now. If you work this up, I would try to work up for a 3.8 implants. 3.3 are just a little, the diameter I think can go a little bit more, and you have more bone there. So with doing such a large osteoplasty, we have a lot of width of bone, so we might be able to push those up to 3.8. Okay. And that will just give you, remember, when you increase the diameter implant, that increases surface area a lot greater than increasing the length, about 30% more. So I think that would be the only thing I would recommend, Larry. Okay. But I like where he has that. Um, that can be just refined later for you. Okay. Any questions on that, Larry?
No, it sounds pretty much what I was thinking.
Yeah.
Yeah.
Oh, no, go ahead.
I yeah, I was thinking of just dentulating the whole case.
Yes.
I think it might
But, but,
work out a lot better than
but,
restoring.
but Larry, always give them that option of keeping the teeth and give them the disadvantage of keeping the teeth. That just because
Yes.
that is an option. Yeah. Okay.
Yes.
Even though it's
Yeah.
not a good option, but they have to understand if they don't do anything, what's going to happen. These teeth will continue to super erupt and the attrition will increase. So, okay.
Perfect.
Okay,
Thank you.
Larry, have a good night.
You
Okay,
too.
Hussein,
Thank you
who do
so
we
much.
have next?
Next is Dr. Bethany Burton. Dr. Burton, would you mind unmuting yourself and presenting your case to Professor Resnick, please?
Hi, Bethany. How are you?
I'm doing well. How are you doing, Dr. Resnick?
Good, good, good. So, what do you have for us tonight?
Well, I guess I have a little bit of a brain teaser. So the one I sent in is basically a failure of mine, and I, for the life of me, have really no idea why. I placed an implant. Originally, it was a BioHorizons guided in site number 19, and I extracted the tooth in November of 22. Bone grafted it, came back in place in June of 23. Delivered an occlusal guard after, and then I removed it in August of 24. Um, Curetted the site, let it heal completely, curetted the site, came back, placed a Han
Okay,
in January of 25. And at least when I placed it the first time, the uncovery is where it seemed like things really went south because everything up to that point was really predictable. And the uncovery, she just had excessive tissue. So I
okay,
actually waited a really long time to actually take the scan and put the crown on it and what have you. But with the second placement, everything went well. I did actually have the penguin at that point too, and so I'd taken readings at the uncovery. The uncovery, I did it with the handpiece, which I
Okay.
usually don't do, but it was a clean
Yes.
uncovery. Everything went well. And the penguin said it was 78, 77, 82 were my readings. That was, let's see, that would have been 10 months after placement. And then I noticed she was in the healing abutment from November until February. And when she came in for us to scan for the crown in February of this year, there was bone loss around it. And this was the CT I took probably a few weeks ago.
Okay.
And there's mobility on it now, and it since came completely out.
Yeah. Have you taken it out?
This is came out on its own. This is gone
Oh, it
now.
came on it. Okay.
Yeah.
Okay. So Bethany, tell me, the first time you placed it,
Yes, sir.
uh, you did a two-stage approach. So you put a cover screw on it, then uncovered it. Is that correct?
Correct. Correct.
Okay. And when you uncovered it, it was mobile, so you removed it, right?
No. When I uncovered it, it was not mobile. The implant itself was, from all of my ability to tell, perfectly fine. The only issue
Okay.
I had with the uncovery was I uncovered it, and then when she came back in 2 weeks later, the gum tissue looked really erythematic, inflamed. It was starting to try to grow back over the healing abutment. So I, redid the uncovery, had her do some
Okay.
rinses. I mean, the patient has great oral hygiene otherwise, and brought her back a couple weeks later. But I mean, that was the part where things just weren't going really predictably. But the implant was not mobile.
Okay. So when did you or why did you take it out then?
So I did take it out because of mobility, but that was after the crown had been on it. She had been wearing
Okay. So
occlusal guard
so
at
you
night.
res
Yeah,
you restored it,
completely.
and then after you restored it, I get it. Okay.
Yes, sir.
So tell me the day, what happened when you actually took this implant out? What did you actually do? So you took the implant out, and then how did you treat it?
I am fairly certain, Dr. Resnick, that the day I
Yes.
took that implant out, it was I mean, I could have probably just waited and it would have taken itself out. It was very uneventful, very
Okay.
not easily. At that
Okay.
point, it looked like there was almost like gum tissue growing between the implant and
Yes.
the bone. And so I don't
Okay.
think I did anything. Um,
Okay. So you took it out. You didn't place a new implant that day, correct?
no, sir.
And you didn't bone graft it.
No, sir.
Okay. And how long did you wait until you placed the second implant?
I removed it August of 24 and I placed the second one January of 25. So how long would that be? That would be
Okay.
4 or 5 months.
5 months. So
Or was it
okay.
longer?
And then the okay. Well, does this patient have any medical issues?
I sent, I don't know if you have it, Dr. Hussein, a full med list. So, you know, she really doesn't have anything that's too outlandish. I guess the only thing that kind of struck me as we were kind of being a little bit more diligent going through things is she does take a multitude of vitamins and supplements that
Okay.
she
Okay.
had written on my medical history is just like a multivitamin
Yeah.
a day.
Yeah. Usually they don't tell us everything they take. So
And then I told
um
her I was scheduling this meeting and she, gave me everything. So
okay.
she has that.
So okay, so Bethany, here's where let's give us a cross section of,
Yes,
first of
sir.
all, Hussein, take those teeth out on the 3D.
And if it would be
Okay.
helpful, Dr. Resnick, I did give him some radiographs kind of throughout this process too, if that would be more helpful than a CT.
Okay. Well, here let's remove the implant, Hussein.
Yes, sir.
It's okay.
The what I want to show you is, do you see where the bone anterior is compared to where the bone
Yes.
is with the implant, and see how that comes down? Okay. So the concern I have is, now give us a cross section of this.
Here we go, Professor.
Okay. And okay, so if you look at this cross section, there's almost no buccal bone left. Even though it looks like there's bone on that 3D image,
Mhm.
there most likely isn't. Or it's very, very thin. You have probably 2 millimeters of soft tissue around the implant. So when you take, well, this implant's already out, but that soft tissue's still in there. So to remedy this situation, to place another implant, you would have to go in and most likely take all that soft tissue out, debride it, and then regraft it. But you're gonna have to regraft that in height.
Mhm.
So um, to gain vertical height is going to be really, really difficult here. Secondly, you'll never know why some implants just don't work. There's so many factors. It's the human body. And I
Right.
don't know if you remember from the lectures when the first implant fails and you replace it,
Yeah.
the
Lower.
success rate goes down to like
Yep.
70%. And
Yes, sir.
then if you go for the third one, it goes to 60%. The reason why it is that way is because those sites are compromised in blood supply
Mm.
and just healing abilities. So they've been traumatized basically, and they just won't heal the same.
Mm.
So with what I see right here, I'm going to recommend, I mean, this patient's been through a lot just with these two implants.
Right.
And to try a third one, I think would be extremely risky and probably not in the patient's best interest. Um, did
Just
you
without knowing why
just
it failed, I don't see it going differently. I
Yeah,
just kind of
exactly.
deferred
And
side.
you know what? It could be one of those 30 homeopathic medications they take, or who knows, whatever is
Mhm.
the situation. This patient has a past history of failed implants, and that's just not good
Right.
because the success rate just goes down. So I just don't want you to stay on this slippery slope, something that's going to get worse and worse. Right now, it hasn't really affected the anterior or the posterior tooth.
Mhm.
It's any one single missing tooth. Let's go back to the 3D image. Um, have you discussed possibly a just a bridge for this case
Yeah,
and
I think
called it?
that's what we're talking about, and I think she very well may have even made peace with just not having something there.
Okay. So
Yeah.
so what I would do is I would give her these options, Bethany. I would say, you've had two implants, they haven't worked out. I would be happy to try a third. However, the success rate is going to be very, very low. You just need to know that. A more higher success would be just to do a bridge and call it a day, or not do anything, which isn't the best idea. But a bridge, I think those teeth look healthy enough. And, it's human body, Bethany. You'll never know why it happened or how it happened. It just does. But I can
There's
tell you
nothing
every
as
time.
far as going through this
Uh,
though that you're like, oh, you definitely messed that up. You shouldn't have done it that
yeah,
way. Like there's nothing obvious going
Bethany,
through.
you didn't do anything wrong. Zero wrong. It, it if you practice implant dentistry, you're going to see long enough, you're going to see these type of patients. That's just the way it is. There's no rhyme or reason. It just, then you could have the same type of area, put in number 19 in, the patient could be a diabetic and smoke and not have any problems. And then you just shake your head. So
Yeah.
don't kill yourself over it, Beth. It
Yes.
it happens that you did nothing wrong. Your placement was great. I like it. Um, you just don't know what the patient's habits are. They could be smoker. They might not be revealing everything on their medical history. I had a case just like this that patient had two failures, and we found out afterwards they were on an SSRI. So they didn't reveal that. And that SSRIs cause a higher implant failure. Proton pump inhibitors do, smoking, cannabis, alcohol, all those could be factors in this. Don't kill yourself. You did a good job. Just go do a bridge and call it a day.
Yes, sir. Thank you for looking at it in your time.
Okay. Okay. You take care. Have a good day.
Thank you.
Okay, Hussein, who do we have?
Next is Dr. Burnham. Doctor, would you mind unmuting yourself and presenting your case to Dr. Resnik, please?
Yeah.
Okay, Michael, how are you? You always have good cases. What do you have for us?
So I got one that I actually posted to the WhatsApp, and I got, I think, 3 or 4 different answers. So I thought this would be good.
Okay.
Yeah.
This will be interesting. So let's see what we have. So
It's an
tell me about your patient.
She's a 47-year-old woman, healthy for the most part, just a history of some hypertension. But medication-wise, I don't recall off the top of my head. I'm actually homesick from work, so I couldn't even go in and pull that up. But she essentially has a low smile line, but she has this chronic abscess on a tooth with a very short root from what I believe is orthodontic. What's the word I'm looking for?
Resorption, root
There we go.
resorption.
Yeah. Thank you.
Okay.
So she has a chronic abscess that's been there, but the bone itself, while there is some resorption in the bone, it's pretty small. And so I was just exploring ideas of what's really possible here because I think theoretically it's possible to do an immediate, but I don't know if that's necessarily a good idea for a variety of reasons. So I just wanted to get your read on kind of what you think, and obviously it depends on my
Yeah.
experience level too. So
Yeah. So Michael, are these teeth mobile? Are the
not at all,
anterior
not
teeth
even a little
mobile?
bit. No, not at all.
Okay. Okay. So they're probably um, sometimes when you get root resorption, orthodontic root resorption, they'll actually ankylose. So, and you don't really see many PDLs there, so it's
Mhm.
possible. So, with that being said, let's take a cross section of that, Michael, and let's see what we have. So, Hussein, ooh, yeah, that is
Mhm.
when you see the short blunted roots like that. And
Yep.
was this a retrograde endo? Did
Uh,
they do an apicoectomy on this?
yes, I believe
Possibly.
they did. Hmm.
Okay.
Yes,
Okay.
and obviously we've ruled out doing another one because the root's so short. So yeah.
Yeah. Okay. Scroll back and forth, Hussein. Okay. Back. Okay. So is this a chronic lesion on that tooth? Have
It
you
is
been,
chronic.
is it
Yes.
okay? So Michael, you probably remember I talk about chronic lesions. The problem with that is the pH of that area has changed.
Correct.
So
Yes.
where that infection is, uh, you could debride that no problem.
Hmm.
Once you take this tooth out, though, especially if this tooth isn't mobile, you're probably gonna take that whole buccal plate because it's probably ankylosed a little bit, which means that you have a ton of bone lingual and you have a
Hmm.
lot of height here. So if you remember, that's a perfect candidate for an immediate placement implant when you
Hmm.
have that lingual bone and the apical bone. But what I don't like is you're not going to have any buccal plate whatsoever.
Right.
So where he has that arrow, that's all going to be removed. Now, Hussein, show him also when you go to debride this, you're going to have to, that bone right there is most
Hmm.
likely necrotic. Okay.
Hmm.
Even though it looks like it's cortical bone, it will probably have to be removed because, again, the pH that is going to be very acidic.
Hmm.
So you're going to have to go into more of that host bone just to get to decorticate it and get it bleeding.
Hmm.
Once you do that, I don't think you're going to have much left. So if you go to try to place an implant, that whole buccal segment is going to be unsupported. And it's going to be similar to a four-wall extraction socket.
Right.
And when the question is, Could you do an immediate implant? Yes. Do you have a
Hmm.
higher possibility of complications? Definitely.
Okay.
What would be the safest and probably the most best prognosis for the patient would be to take the tooth out,
Hmm.
debride it real well, decorticate it, get it bleeding, bone graft it, come back in when the hard and the soft tissue is healed, and then
Hmm.
place the implant in the ideal position. So I think that would be
Yeah.
the highest success rate. That's not to say you couldn't do it. I just think that, what I don't want to see is, even though you say this patient has a low smile line, what you don't want to end up with is a tooth that is 1.5 times as long as the adjacent tooth,
Yeah,
because
absolutely not.
th-
No, no, no.
that i- that
Yeah.
im- that implant's going to be more apical. Okay, that's
Hmm.
just the bottom line. You're going to have a larger clinical crown. It's going to be an FP2, not an FP1. So
Yep.
I think if you graft it real well, you'll be able to get an FP1 and it'll be more predictable. Okay.
Yeah, that's no problem. And I think I just needed you to talk me off the ledge a little bit. So thanks.
Yes,
The
and
only.
so Michael, you'll never be questioned on why you were conservative. You'll always be questioned if something goes wrong and you rushed it,
Right.
especially if you didn't give the patient. And I believe Hussein's going to talk about, there's another issue over here
Hmm.
on the left. Did you see that, Michael?
I do believe that's in her treatment plan, but I haven't been into work this week. So,
Okay. Yeah.
yeah, just go ahead and go through
I
it. I'm not sure. Yeah.
Yeah, I would. It looks like you have possibly a failing root canal there. You have
Yeah.
a radiolucency around it.
Hmm.
Hussein, what's the situation here?
So, yes, sir, we do have a short tooth. It's an endo-treated tooth. It seems as if we've got bone loss around that implant, maybe periodontal lesion as well over here to the proximal aspect of that tooth. It it doesn't look that great over here, Professor.
Okay. Yeah. So Michael, what I would do, I would follow that up with a periapical X-ray,
Hmm.
evaluate that tooth. That might be almost in the same situation where you take that out, that's definitely not an immediate implant.
No
That's
way.
going to be a preliminary graft, called a preliminary graft, because there's not going to be any bone there. And you're
Hmm.
probably going to have to do is do a sinus graft after the preliminary graft. So take it
Okay.
out, graft it, but tell the patient they'll probably need at least a bump or
Hmm.
possibly a crestal graft after that.
Awesome.
Okay?
Thank you. Yes. One quick question I wanted to clarify. When
Yes.
you said the necrotic bone on number 8, do you mean just decorticate, poke holes in it? Or are you saying do something more there? What exactly did you
No,
mean?
so I want you to decorticate it and then
Okay.
go in with like a 557 and
Okay.
decorticate it real well. What I
Okay.
want you to do is to change the pH of that area to a
Hmm.
more ideal pH for that bone to remodel and regenerate.
Makes
If
sense.
not, that might not heal as fast as you'd like it to be. Okay.
Perfect. Thank you.
So
Thank you both very much.
get it bleeding real good. Okay.
Okay. Yes, sir.
Perfect. Take care, Michael.
Thank you.
Okay. Next case, Hussein. Who do we have?
Yes, sir. We've got Dr. Gupta. Dr. Gupta, would you mind unmuting yourself and presenting your case to Professor Resnik, please?
Hi, Dr. Resnik.
Dr.
How are
Gupta,
you?
how are you? You always have very good cases too. So tell me, what do you have for us tonight?
So, I have this 57-year-old male who, with medical history of hypothyroidism, he's taking levothyroxine for this, and recently he's been taking gabapentin for nerve overactivation in right groin. He's been
Okay.
complaining. Actually, this does not look like my case, Dr. Hussain. I had a
Oh,
failing implant.
okay.
So, okay,
So
number
what
19, and yeah.
Is it
that,
this is 19, isn't it? Yes.
Yeah,
yes,
but my patient
sir.
had implants in 18, 19, and 20.
Oh,
Okay.
okay.
Yeah.
So that was the
Let,
CBCT we've actually received. I'm sorry, Dr. Resnick,
Uh-oh.
please go ahead, sir.
okay. Check the patient's name on this. Can you
Um,
check on the CT? Do you have it?
I actually do delete the patient name, sir,
Okay.
just to make sure. But was it? Yeah, I think we've received an old one, Dr. Gupta, because the submission date on this one is Jan 2nd, 2024. So it might be either uploaded wrong or I might have the wrong patient. But would you mind if I
Yes.
could pass your case to Dr. Resnik through email and I'll make sure to pass his feedback to you?
Yes,
At
Yeah,
that
no
time, I
problem.
do
No
apologize
problem.
about this.
Doc, here, let me tell you what will happen. Hussein tomorrow morning will get the right case. He'll send it to me. I do have your email. I'll look at it tomorrow and I'll get back to you tomorrow on it. But just so I know what I'm looking at, it's a failed 19 implant.
So patient is
And
complaining, yes, it looks like this implant was placed at another dental provider, at another dental clinic 3, 4 years ago. He has implants on 18, 19, and 20. He's complaining of some discomfort while water flossing specifically on 19 buccal area. So I wasn't sure. It looks like the implant is very close to eye nerve, so I wasn't sure what is the best treatment approach for him. Should I be treating him for peri-implantitis or restoration change, or should we be replacing the implant?
okay, so he's complaining of soft tissue irritation on the
Yes,
buccal.
yes,
Okay. Have you compressed the buccal lingual plates?
yes, I did. He did not complain of any pain except when I was probing that area, just the buccal. When I touched the implant with the probe, he did feel a little shock, but nothing
Okay.
major.
Is it a screw or cement retained
It's a
prosthesis?
screw retain.
Okay. Okay. So here, let me look at it
Sure.
tomorrow. I'll get back to you by tomorrow night and we'll talk via email or if have to, we'll do it on the phone. Okay.
Absolutely, Dr. Resnik. No
So
problem.
Hussein will get that tomorrow. Okay.
All right. Thank you.
Okay. Thanks, Doc. Okay.
Thank you,
Okay.
sir. And thank you, Dr. Gupta. Next case, sir,
Thank
is for Dr. I'm sorry, I'm going to pull the name. It's for Dr. Cragen. Dr. Cragen, would you mind unmuting yourself and presenting your case to Professor Resnick, please?
Hi, Doc. How are you? Hello, Brad.
Let me check
Is
really
he on?
quick. No, I don't think he's on. So we could possibly go to the next case, Professor, and that would be for Dr. Augustine. Dr. Augustine, would you mind unmuting
Oh,
yourself and
Maggie.
presenting to your case?
Oh, hello.
Okay.
And
Hi, Maggie. How are you?
I'm good, thank you. Let's buckle up for this one. Um,
Okay. So
it's
what do we
always
have?
it's always a good time. So I first met this lady. She came in and the first thing she says is, I got a bunch of veneers and I want to sue my dentist that placed the
Okay.
veneers. And I talked her out of it. She went back. He redid the veneers. He also does all on X's. And the case is still a mess. There's a ton of decay under the new veneers. And I'm completely not involved in that, still trying to convince her not to do anything legal, but rather allow me to help her out with the upper veneers. So if you're seeing some of that, that is still an issue. 14 and 15 of the CT scan, you will also see she's seeing a periodontist. 15 needs to be removed. 14, the periodontist suggested doing a bone graft on the distal part of that. So I just wanted to kind of summarize that.
Okay.
On the
So,
lower, yep.
oh no, go
Uh,
ahead. Go ahead.
on the lower, she would like to rebuild her chewing ability. Okay.
Okay.
And so the question is surrounding whether or not, because initially when I planned this case, I was not doing ridge augmentation. So I just thought I'd place implants. Now they would be fairly small and the crowns would be fairly large. And so I wanted to consider whether or not we should do ridge augmentation on both sides or just one side, and whether or not that made sense as opposed to just placing the implants. As far as her medical, so this patient is older, she's in her 60s, and her medical condition, she has hyperthyroidism for which she takes medicine, and I don't remember the medicine name, but that's under control.
Okay.
And she is also diabetic. She takes metformin and Ozempic. Her A1C is 6.3. However, in the past,
Okay.
that has been that has not always been that low. Although she admits that when it has not been that low, it's because she was not very compliant with taking her medication.
Okay, perfect. Perfect. Okay. So let's come back to the medication issue. Let's get a good look at this case. So Hussein, let's extract the teeth.
Sure.
Not that we're going to extract them, but I want to show you. So if we extrapolate a buccal line, so this is the buccal plate. So everyone on the call, you can see that we've lost a lot of the buccal bone here. So as you know, after an extraction, the buccal plate resorbs from buccal to lingual. That shifts the whole ridge more lingually. Now, with the sublingual undercut, then it actually shifts back to the buccal as it decreases vertically. So we know horizontally, Maggie, right off the bat, we've lost a lot of bone. So now, Hussein, let's go and look from a lateral view and see what it looks like laterally. Okay, so the left side, Maggie, look how that is really decreased in height. Okay, significantly. And let's look at the other side.
Right away, sir. Here we go.
Okay, perfect. Now, I believe Maggie, you were looking at doing 2 implants on each side.
That's
Is that
correct.
correct? Okay. Now, that is the most critical part of this treatment planning, that you get that right. And Maggie got it right. You always want to do 2 implants. 1 implant for a case like this would never work out. The reason is because of the port to crown implant ratio, it just would be compromised. Hussein, could you go ahead and show us with the implants? I see that you placed 2 on each side.
Yes, sir.
And then, okay. So with that being said, that is the ideal treatment plan. Now, um, because of the compromised crown implant ratio, that is a vertical cantilever. When you have 2 implants and you splint them together, that basically gets rid of those force factors. With the vertical cantilever, even with a compressive force, by the time that force gets down to the crestal bone, it's a shear force. That's why you have to be very careful. So 2 implants is very good. Secondly, if you look at where Dr. Hussein put the implants distal to the teeth, see how they're not right up against the tooth, because what would happen if you get it too close to the tooth, you know, we want to be 1.5 to 2 millimeters away. However, on a case like this where there's a vertical discrepancy, you want to be a little bit further to maintain the blood supply on that bone. So with that being said, he has those implants positioned ideally. Now, as you can see those implants, let's look at the other side also. Okay. And so Maggie, you have 3 millimeters probably on each implant that the buccal is going to be exposed. We know that ideally we want 2 millimeters of bone on the buccal. With that being said, if we don't have enough bone there, what will end up happening is it will just resorb back and you're going to have failed implants. So the next thing we have to look at is what type of nerve we have and if we have enough room below the apices of these implants. So Hussein, could you show us each implant and show us where we're at with relation to the bundle? Okay, so if we look at the canal, that's a good 3.5 millimeters away. Keep going. And the same with that. Okay, so we're good there. Let's look at the other side.
Right side, sir.
Okay. Okay, this is the right. Okay. And okay, we're good. And it looks like Maggie, you're going to use Bi-Horizon implants on this. Is that correct?
Yes.
Okay. So are all these implants 4.6? Hussein?
4.6. Yes, sir. We're actually using 4.2 at implant number 20, sir. But for the molars, we're using 4.6.
Okay, that can be changed after the bone grafting. Okay, so let's go back to the 3D image. So just for everyone on, let's just look at one side, maybe the left side. Okay, there we go. Now let's get rid of all the implants. Okay, so if you've taken our bone grafting course, you know I talk about there are easy graft cases and there's hard graft cases. This is going to be an easy graft case and a very successful one. I'll tell you why. Number one, we won't have any problems with getting primary closure because we have no teeth distal here. So Hussein, could you move that out of the way? Yeah, okay.
Yes,
So
sir.
show them distally. Let's look at it straight on. Or from an occlusal. From an occlusal will be
Oh,
better.
lose a few. Here we go, sir.
Okay. So Maggie, if on your incision, you're going to make a crestal incision and then you're going to come out almost by the external oblique. And can you show her that, Hussein? Okay, now stop right there. There you go. Okay, perfect. So that's going to basically be your incision. So you'll be able to rotate that whole flap anteriorly. Secondly, if you look at this defect where the crown, the implants were, this buccal defect is a concavity. So that's a concave um, edentulous site. With that being said, that holds the bone in better than any other site. If it was straight or if it was convex, the bone just slips all away. So with this one, it's going to be very, very good, very easy to put tent screws in, bring that flap anterior because you can't stretch the flap right over the nerve because you have four branches that come up in that soft tissue. So we're going to have to do it all distally, and you'll rotate that anteriorly. You'll be able to cover it no problem with a membrane. So what I'll do on this case, Maggie, do you have this scheduled, Maggie?
No, she wants to schedule it. I just did all the scanning. So, and I won't be, I mean, it won't happen until the beginning of June because I have to be back in the office in this next 2 weeks is kind of tricky. Or we're gonna have because of the
Okay.
holiday and everything.
Yeah, so what I would do in the next couple of weeks, Maggie, send me an email and we'll go over this case start to finish. Um, we'll plan it out. As you know, I have the 8 steps to ridge augmentation. We'll go through step by step on how to do this. This is going to be a good case for you. You'll
Okay,
be able to grow a lot of bone very easily on this case. So,
thank you. And part of
um,
the reason why I shared her desire to sue another dentist is, that's always a red flag for us, right? So, and
yes.
you and I have talked about some ridge augmentations that I've done that haven't been entirely successful. And so I want to pick the right case and I want to do it the right way and I want to have the right patient. And so,
It, and this is the only thing that you have to remember is this patient is a diabetic. Just because their A1C is 6.3 doesn't mean that they're not compromised. So we're going to get a very good informed consent. You're going to give that to her prior. You're going to discuss it. You're going to document it. And then you're going to give her all the information. And if she wants to go forward with this, then this is not going to be a problem whatsoever. Even if the bone graft would not heal correctly, medical legally, you have no problems as long as you give good informed consent and you do it the right way, which you will do it the right way. So I'm not worried about that at all. Um, when you look at a patient that is suing another doctor over aesthetics, veneers, those are hard cases. Patients' expectations a lot of times are are problematic, especially I see them on veneer cases. I see them on all in X cases. So your goal is to educate the patient as much as you can, and we'll have you educating this patient before it's done. So just don't rush into it. You'll get it done, but let's talk in the next 2 weeks, okay?
Okay.
On
Thank
this
you,
one.
sir.
And just so everyone understands, the 2 implants on each side, they will be splinted. You will have a very narrow occlusal plane. So it's going to look like this patient has all bicuspids all the way back. The reason is that you don't want a buccal and lingual cantilever on the crowns because those are going to be shear forces. With the crown and bridge or restorative dentistry on the upper, we have against natural teeth. It looks like you have a little bit of super eruption, possibly on those upper teeth. We're going to have to explain that too. So you might have to do some selective grinding of the plunging cusps of those maxillary teeth. We'll put that in the treatment plan also. Okay. Okay, is that good, Maggie? Any questions?
Perfect. Yep. Thank you. Thank you very much for doing this. Both of
Okay,
you.
perfect.
So,
We'll talk to you soon.
great.
Okay. Okay, Hussein, who do we have next?
So I think I'm just going to ask if Dr. Harvey Chin is here, Professor, because Dr. Chin is our last doctor for the day, but I don't think he made it in for today's meeting. Otherwise, Professor, we're done for the day. We went through all of our cases, and back to you, sir.
Okay, so Dr. Chin had 2 cases, I guess.
Yes,
Wow.
sir. That's
Okay.
true.
Okay. Is Dr. Chin on by chance?
I don't think so, sir. I'll check
No.
the
Okay.
participant list. No.
Okay. Well, okay, so we got done at 8 o'clock.
4 minutes
So
early.
anyway, yes. Thank you again, Dr. Hussein. I see that
Thank you, Professor.
Dr. Robinette was busy with some questions. So I thank everyone for coming on. If you have any questions, let us know. If not, we'll see you next month. Get your cases in early. And thank you again. Have a good night.
Thank, thank you, Professor. Thank you, everyone.
Good night.
Good night, sir.
Is it auto?